Hello, everyone. Good morning, good afternoon, and good evening. We have a truly global audience today. Welcome to today's session, and thank you for taking the time from your busy agendas to be with us today. My name is Filomena Gonçalves. I'm a Senior International Marketing Manager at Natus Medical, and I will be your host today. Before we get started, I would like to go over a few housekeeping items so you know how to participate in today's event. This webinar is being broadcasted on a webcast mode, which means that all of your lines are going to be muted to manage background noise during the presentation and ensure you have a good experience. We will allow time for questions at the end of the presentation. Please type in your questions into the question box on your screen. You can open the question box by clicking the white arrow in the control box. You may type in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. This meeting is being recorded and it will be available for you to review it later at the Neurotraining Academy website. Today's webinar is about status epilepticus, and without further delay, I'm going to introduce our speaker for today, Professor Sándor Beniczky. Sándor Beniczky is a board-certified neurologist, clinical neurophysiologist, and epileptologist. He is a professor at Aarhus University Hospital and is the head of the Clinical Neurophysiology Department at the Danish Epilepsy Center. He is the chair of the joint task force of the International Federation of Clinical Neurophysiology and the International League Against Epilepsy, member of the International League Against Epilepsy Commission on Diagnostic Methods, International League Against Epilepsy Education Council, and the Executive Committee of the International League Against Epilepsy in Europe. He is editor-in-chief of Epileptic Disorders. The main research interests of Dr. Beniczky is EEG and epilepsy, focusing on electromagnetic source imaging, seizure detection, standardization, and quality assurance in clinical neurophysiology. He has supervised 8 Ph.D. students and is the author of over 133 peer-review papers and 21 book chapters. Professor Beniczky, welcome. The floor is yours.
Thank you so much, Filomena, also for the nice introduction. I would like to welcome you to this webinar on EEG and status epilepticus, and I would like to express my gratitude to Natus for organizing this. So I'm going to start my presentation now. So today we will talk about EEG in status epilepticus, and this is the outline of my presentation. So I will talk about the classification of status epilepticus according to the International League Against Epilepsy. I will focus mainly on semiology and EEG. Then I will discuss with you the role of EEG in diagnosing status epilepticus. I will show you EEG patterns, and we will discuss the criteria for diagnosing status epilepticus. Then I will discuss with you the diagnostic accuracy of EEG in non-convulsive status epilepticus. I will discuss the role of EEG in management of status epilepticus, focusing on the monitoring of the therapeutic effect and monitoring brain function during withdrawal of anesthetic drugs. So in 2015, the International League Against Epilepsy issued the relatively new classification of status epilepticus, and then they used 4 axes to classify status epilepticus: the age, etiology, EEG, and semiology. And of course, EEG and semiology go hand in hand. They set up the electroclinical correlation, so we'll look at them together. So the new classification defines 2 major groups: those with prominent motor symptoms and those without prominent motor symptoms, that is the non-convulsive status epilepticus. Well, you can diagnose those with prominent motor symptoms even without EEG, although EEG is really useful if you want to monitor the therapeutic effect, but just for diagnosis, you can do without EEG. However, for diagnosing non-convulsive status epilepticus, EEG is needed. So we will focus on these aspects. Now, it's very important to emphasize that these two categories are not separated. There is usually a dynamic relationship. So a patient can start with convulsive status epilepticus, and then because of the electroclinical burnout, it will continue with a non-convulsive phase and then come back to a convulsive phase. So don't think of these as two separate entities. There is much dynamics and much interaction between these groups. So if you read EEG, then you know that there is a wide variety of ictal EEG patterns. And no surprise, there is also a wide variety of status epilepticus EEG patterns. So what EEG features will help diagnosing non-convulsive status epilepticus then? Well, obviously, one single criterion would not work. So you really need a set of combination of several criteria that cover broadly the ictal EEG patterns to get a good sensitivity, yet not catching too many false positives to get a good specificity. There have been several attempts to develop EEG criteria for non-convulsive status epilepticus, and probably the oldest one is by Young and colleagues from 1996, and most of the later criteria were derived from this one. So in 2005, Chung and Hirsch published criteria, and then Peter Kaplan in 2007. Now, at the fourth colloquium on status epilepticus in 2013, a panel of experts described the most common patterns, and then we had a consensus discussion that led to these criteria that today are known as the Salzburg criteria for non-convulsive status epilepticus. So this table is a little bit boring, so let me guide you through the flow chart for the Salzburg criteria. Well, the starting point is a clinical suspicion of non-convulsive status epilepticus. So EEG and the Salzburg criteria are not just screening methods, so you really need an indication. And according to the new definition of status epilepticus, then you need at least 10 minutes of symptoms. Now, if you cannot explain a disturbed consciousness with other methods or other etiology, then you think of non-convulsive status epilepticus and you record an EEG. Now, if you see epileptiform discharges continuously with a frequency over 2.5 cycles per second, then you can already diagnose non-convulsive status epilepticus. This is actually the easiest criterion how the Salzburg criteria can be fulfilled. And we thought that this would be really straightforward in a clinical practice. But then when we looked at how people apply the criteria, we realized that we need to specify this a little bit in more detail, because what we've noticed is that often people just measure the duration of one cycle, and then they take the reciprocal of it, and then they infer the frequency out of this. Now, this is misleading because what we call a rhythmic discharge is actually a quasi-rhythmic. So if you just measure one or two examples of the cycles, then this may not be representative. Or the other error is just picking 1 second and counting how many cycles are in 1 second. Again, because the rhythm is quasi-rhythmic, actually, this can be misleading. So the best way of doing this is to take 10 seconds epoch and then count the number of discharges during this 10 seconds period. So when we realized that we need some more definitions for the Salzburg criteria, we published this companion paper 1 year later. And here we explained how to apply the Salzburg criteria in more detail. So for example, here you can see an EEG, and this blue box shows you the 10 seconds epoch, and then you count the spike and wave cycles during this 10 seconds epoch, 31 spike waves. So this satisfies our first criterion. Yes, but what if you can see epileptiform discharges, but their frequency is lower than 2.5 cycles per second? Or there are no epileptiform discharges at all. However, you can see continuous quasi-rhythmic delta or theta activity with a frequency over 0.5 Hertz. But in this case, you need some secondary criteria. So in this gray box, I will show the secondary criteria. You need at least one of them. Well, one secondary criteria is the typical spatio-temporal evolution. So if you are reading EEG in epilepsy monitoring units, then you are familiar with the typical evolution of an ictal pattern. Like here you can see to the left, the ictal discharge starts with a high frequency, low amplitude signal, and then there is a gradual change. As you move forward in time, the amplitude increases and the frequency decreases. You can also note gradual change in morphology, and then you can also see a gradual change in the location. So first it starts only on the left side, and then it propagates also to the right hemisphere. So there is a spatio-temporal dynamic evolution. We defined in detail how the sequential change in voltage and frequency and the evolution in frequency and change in location looks like. The other common error that we've encountered during the clinical application of the criteria are these. So this is an infographic symbolizing a quasi-rhythmic discharge, and this is what you need. And then this is symbolizing a polymorphic delta activity. So when we refer to rhythmic activity, we thought of the first one and not about this polymorphic delta activity, which is a non-specific finding. Okay, so another secondary criteria is that you see subtle clinical ictal phenomena during the EEG patterns mentioned above. Now, what can be a subtle semiology? These are discrete phenomena like twitches of the eyelids, twitches in the face, jaw, extremities, or the trunk, or head or eye deviation, or some peculiar automatisms. Well, you might be familiar from cardiology with the phenomenon of electromechanical dissociation. This is very similar also in status epilepticus. Now, let me show you some examples of subtle seizures. So look at the perioral twitches here. Or you can look at the tiny twitches in the left thumb. This can go on for hours, and then it can continue with a full-blown seizure like this shown. Well, the challenge here is that many etiologies in the patients in the intensive care unit, and even the medication they receive can mimic these subtle ictal phenomena. So in a study, we looked at the semiology, so what kind of phenomena are there, the body parts, the occurrence, and tried to use only semiology to distinguish those that are due to status epilepticus and those who are due to other causes, and we could not do that. So you really need EEG to identify the status epilepticus also in the cases with subtle clinical manifestations. Okay, another secondary criterion is that you give intravenous anti-epileptic drug. This is not for treatment. This is just to see the modulatory effect both on the EEG and on the clinical picture of the anti-epileptic drug. Now, if you can see a clear improvement in the EEG and also a clear clinical improvement, then you can diagnose non-convulsive status epilepticus. For example, in this case, you can see continuous epileptiform discharges, but their frequency is not high enough to fulfill the first criterion. But then after you give the intravenous anti-epileptic drugs, you see both an improvement in the background activity, the epileptiform discharges disappear, and then if you can see also a clinical improvement, then you can diagnose non-convulsive status epilepticus. However, this is really a best case scenario. What we often see in the clinical practice is clinical improvement is not so obvious because the patient, for example, is sleeping after the IV anti-epileptic drug administration. So you cannot really conclude on the clinical improvement, yet you can see a clear-cut improvement in the EEG. Now, in this case, you are not sure that this is non-convulsive status epilepticus, so we define this as a possible non-convulsive status epilepticus. Now, another phenomenon that needs to be discussed here is the fluctuation. So as you remember, the evolution is a gradual change in the same direction. However, the fluctuation is like a ping pong. So from 2 Hertz, for example, it goes to 2.5 Hertz and then back again to 2 Hertz and 2.5 Hertz. So it's not a 2-step gradual change in the same direction. Well, if you see fluctuation and no other secondary criterion is fulfilled, then you conclude this is a possible non-convulsive status epilepticus. Now, there are some additional aspects that need to be discussed here. So first, how long do you need to record an EEG epoch that fulfills this criterion? Well, in our original description, this was 10 seconds. And then people can't understand how we can diagnose non-convulsive status epilepticus in 10 seconds. But that's not what we are saying. What we are saying is that the climax of the abnormalities in the EEG needs to be there for at least 10 seconds. But you can see the very first starting point in this algorithm is the clinical suspicion of non-convulsive status epilepticus, and that has to be there for at least 10 minutes, according to the new definition. Now, the rest of the EEG is, of course, abnormal too, but the climax, where the criteria are fulfilled, has to be there continuously for at least 10 seconds. Now, there is a special challenge in patients with epileptic encephalopathy or developmental encephalopathies. So for example, in children with West syndrome. So these poor kids have a horrible EEG also in the interictal state. So if you just record an EEG in the interictal state, you can easily fulfill the Salzburg criteria. But to avoid the false positives in this group, we impose additional criteria specifically for patients with epileptic encephalopathy. So in this case, there is also a need for a worsening either of the EEG, and you can easily conclude on that because most of these patients have many previous EEGs, so you can compare your recording with the previous recording. Or the caregivers have to tell you that there is a clear-cut worsening, or you make this branch of the criteria compulsory, where you administer intravenous anti-epileptic drugs, and there must be an EEG and a clinical improvement to diagnose non-convulsive status epilepticus in this subgroup of patients with epileptic encephalopathy. How accurate is this? Does this work in all the different types of non-convulsive status epilepticus? Well, I have to emphasize that none of the non-convulsive status epilepticus criteria previously published have been ever clinically validated. So we looked at the diagnostic accuracy of these EEG criteria, but when you want to do a formal clinical validation study, then you have a big challenge here, and that is the lack of a proper gold standard. So in clinical practice, we consider EEG as gold standard for non-convulsive status epilepticus, but then what's the gold standard for the gold standard? Well, in such cases, you can derive the gold standard from consensus decisions inferred from multimodal data. And that's what we applied in our study. We looked at all clinical data, all paraclinical data, EEG readings not assessed using the Salzburg criteria, so assessed by experts, but before the Salzburg criteria were published. Then we included laboratory data, neuroimaging data, and very importantly, the therapeutic response, the follow-up, and the final outcome. So we infer the gold standard from the multitude of these factors. So we completed the study according to the START criteria, the standards for reporting diagnostic accuracy studies. 3 centers participated: the Danish Epilepsy Center, Aarhus University Hospital, and the Paracelsus Medical University in Salzburg. The EEG was evaluated blinded for the Salzburg criteria independently by 2 experts. And then we included 2 groups. Both were consecutive. We had a validation group where the input, the indication for EEG, was a clinical suspicion of non-convulsive status epilepticus. But then we also had a control group to focus on the specificity. And this control group consisted of abnormal EEGs, but without any clinical suspicion of non-convulsive status epilepticus. The inter-rater agreement was really high in all the groups, almost perfect, more than 0.87. And here you can see the study flow chart. So in the validation group, we had 120 eligible patients. 50 of them fulfilled the Salzburg criteria. And then later on, the gold standard showed that 42 of them indeed had status epilepticus. So we had 42 true positives. But then we also had 8 false positives. So they fulfilled the Salzburg criteria, yet the gold standard showed that they did not have status epilepticus. Then 70 of our patients did not fulfill the Salzburg criteria, and the gold standard only showed that 1 of them had non-convulsive status epilepticus. So altogether, we had 43 patients with non-convulsive status epilepticus, and we only missed 1 of them. Now, in the control group, we had 100 consecutive patients. 3 of them fulfilled the Salzburg criteria. Of course, none of them had non-convulsive status epilepticus. It turned out that all these 3 patients had seizures, and that's where the EEG fulfilled the Salzburg criteria. Yet the seizure stopped, so it did not become status epilepticus. So out of this, you could conclude that Salzburg criteria are actually very good seizure detectors, but you need the proper clinical background, the proper clinical context to conclude this is non-convulsive status epilepticus. So the sensitivity of the criteria were pretty high, close to 100%. Specificity was lower. We had 8 false positives. This gives an overall accuracy, which is again over 90%. Now, these accuracy data are for the case where we use the 10-second sliding window, as I described before. And then we considered as positive both the definite and the possible non-convulsive status epilepticus cases. Now we tried to play a little bit with these parameters. So we looked at what would happen if we would take 30 seconds or 60 seconds as the minimum continuous epoch where the EEG abnormalities have to fulfill the criteria. Well, of course, if you increase the duration of the epoch where you must see these abnormalities, then you increase your specificity, but not so much, so from 89 to 92%. But this is at the cost of dropping the sensitivity, and this drop was significant from 97 to 86%. So it's better to stick with the 10 seconds criteria. This was shown also by the receiver operating characteristics also. Then we also looked at what would happen if we would consider those with possible non-convulsive status epilepticus as negative. Again, you increase your specificity from 89 to 97%, but then you would lose a lot of your sensitivity. So it's a drop from 97 to 69%. So better consider those with possible non-convulsive status epilepticus as having the condition. Then we compared the subgroups of patients with coma, non-coma, post-hypoxic, non-hypoxic, those with pre-existing epileptic encephalopathy, without epileptic encephalopathy, those with pre-existing epilepsy and without. And this worked pretty well in all these subgroups. And the reason is that you don't have one single criterion. You have a set of criteria, so it covers broadly the EEG patterns. So based on these results, we concluded that the Salzburg criteria for non-convulsive status epilepticus have high diagnostic accuracy, have an excellent inter-rater agreement, and they are suitable for implementation in clinical practice. Now, in the next edition of the ACNS, American Clinical Neurophysiology Society, in the next edition of the terminology for the critically ill patients, which I hope comes this year, we will include also electrographic seizures and non-convulsive status epilepticus, which was not described in detail in the previous editions. So now we will have all in one paper, I hope. And then these new aspects will largely be based on the Salzburg criteria, although with some minor modifications. So for seizures, we will use pretty much the Salzburg criteria, so epileptiform discharges at a frequency over 2.5 cycles per second for at least 10 seconds, or evolving pattern, or patterns with time-locked subtle seizure manifestations, or an EEG and clinical improvement with intravenous anti-epileptic drugs. And then for status epilepticus, we had to adapt them for the critically ill patients because, as you remember from the flowchart, the first input is a clinical suspicion of 10 minutes of symptoms. But of course, if the patient lies in the intensive care unit, you cannot really apply this. So instead of that, we said that we need at least 10 minutes of EEG abnormalities, or a total duration of, we are still debating, but either 20 or 50% of 60 minutes period. So I hope we will reach consensus soon and we will publish the paper. Now, fulfilling or not the criteria, that sounds like a dichotomy, so yes or no status epilepticus, but the reality is not so black and white. So we need to discuss also aspects related to the ictal-interictal continuum. So there are some EEG patterns that indicate that there is a high seizure risk, yet they do not fulfill the criteria. So we know from this large retrospective study that lateralized periodic discharges have a high association with seizures regardless of their frequency. And of course, the association is greater when you have plus modifiers. For lateralized rhythmic delta activity and generalized periodic discharges, you have high seizure risk, especially when their frequency is over 1.5 Hertz or plus modifiers are present. Of course, if the prevalence is higher, the frequency of these abnormalities is higher, then it suggests an increased, even more increased seizure risk. So here you can see lateralized periodic discharges over the right hemisphere, and then you can see also the superimposed fast activity. And here you can see generalized periodic discharges. You know that they are synchronous, bilateral synchronous, and symmetric. Here you can see lateralized rhythmic delta activity. And then here's a plus modifier too. There is a superimposed sharp wave. Well, a relatively new term is the BIRD, the brief, potentially ictal rhythmic discharges. They can be focal or generalized, sharply controlled rhythmic activity with a frequency over 4 Hertz. They are very brief, between 0.5 and 10 seconds, but at least 6 cycles have to be there. They are not consistent with a known normal pattern or benign variant. Birds are associated with seizures, so if you can see birds, then you have 75% association with seizures, and in the patients where no birds were noted, this was only 25%, so the difference was significant. So here you can see birds in the theta frequency domain. Here you can see birds in the beta frequency domain. And here you can see birds in the alpha frequency domain. Okay, now let's see how we can use EEG for monitoring the therapeutic effect, the induced therapeutic coma when you administer the anesthetics. Here EEG shows you very well the gradual progression towards the isoelectric EEG, because first you can note an increase in the beta power, then increase in delta power, then beta is declining, and then when you induce, there is suppression with increasing duration, then burst with decreasing duration until you reach the isoelectric EEG. And then at the withdrawal, everything goes in the opposite direction. So when you start the weaning, then first you see burst with increasing duration, suppression with decreasing duration, and so on. Well, all experts would agree that the goal of the therapy is seizure suppression. But then there is a controversy on how deep the sedation should be. In our center, we go for burst suppression. For example, we target bursts that have a duration up to 5 seconds and suppression with a duration between 8 and 12 seconds. Some centers go for a total isoelectric EEG, but as I said, this is still controversial. Here you can see a nice burst suppression pattern. And here you can see a totally suppressed EEG. These are just the ECG artifacts on it. And then you can use EEG to monitor the brain function during the withdrawal of the anesthetics to see whether the seizures or the status epilepticus would return. What you look for is the emergence of EEG patterns indicating increased seizure risk. However, there is an important caveat I have to mention here. There is a paradoxical effect of drug withdrawal. So the weaning of the anesthetics induces actually a hyperexcitability. And there were published successful wean cases despite emergence of the ictal-interictal patterns during the weaning. So be very cautious in not overreacting if you see abnormalities during the week. So to wrap it up, you can use EEG to diagnose and classify status epilepticus. When it comes to diagnosing non-convulsive status epilepticus, EEG is a must. Then remember that there is a dynamic evolution, so convulsive status epilepticus can turn into a non-convulsive status epilepticus and back. So concerning the ictal pattern during the seizures, you can use the Salzburg criteria, but also keep in mind the ictal-interictal continuum and the bursts. You can use EEG to monitor the therapeutic effects during the induced coma. of course, you go always for seizure suppression, and then depending on your local guidelines, you go for burst suppression or even an isoelectric EEG. And then you can use EEG to monitor the brain function during the weaning, but please remember the caveats that I've just mentioned, the paradoxical effect of the weaning. Thank you so much for your attention.
Thank you so much, Professor Beniczky. It's been a very, very interesting and informative session. We are now going to begin answering the questions, and our participants that they have been extremely engaged, they have already submitted some very interesting questions. So here's the first one. Do you recommend EEG monitoring during cooling for cardiac arrest? How common it is in status epilepticus, and how does it affect the outcome?
Yes. So our Swedish colleagues from Lund have published several papers on targeted temperature management and EEG. Eric Westphal and Sophia Beckman have some nice papers on this. What they found is that the so-called malignant patterns like suppression or burst suppression or an earlier occurrence of epileptiform discharges has a high specificity for a poor prognosis, though the sensitivity was lower, and the continuous EEG, normal voltage continuous EEG, the so-called benign patterns, have a good specificity and sensitivity around 75–80% for a good outcome. Now, how often you can see status epilepticus in these patients? Well, this depends very much on the setting, on the study, on the center, the criteria, but it varies widely between 5 and 30%.
Okay, thank you so much. We have another question, which is, which anti-epileptic drug is better to see the clinical changes or changes in the EEG in a non-convulsive status epilepticus?
Well, I must admit we didn't fully standardize this in the Salzburg criteria, but what usually we do is we start with benzodiazepine, and if that doesn't work, then of course we also test the modulation of the EEG and of the clinical behavior with second line drugs like valproate or levetiracetam. Of course, then you would do a longer recording.
Very good, thank you. We have had another question that it was very similar to this one and has been responded. Which is the GCS of the control group that you have presented?
Yeah, so I guess you are asking about the Lancet paper. Well, in the control group, we had patients with abnormal EEG, so we didn't specifically collect patients with seizures. However, it happened that 3 of the patients in the control group happened to have seizures besides the abnormal interictal EEG. To my recollection, none of them had generalized tonic-clonic seizures. They all were focal impaired awareness seizures. Now, all these 3 patients in the control group with false positive result, they had seizures. So actually we could say that the Salzburg criteria are good seizure detectors, but of course you need also the clinical criteria to diagnose non-convulsive status epilepticus besides the Salzburg criteria.
Thank you very much. We have another question. The use of benzodiazepines leads to EEG depression and decreasing of consciousness. Non-sedative anti-epileptic drugs needs time to loading dose. How can you confirm the real, not possible status epilepticus in such a case?
Yeah, it can be tricky, but it's not that bad, especially if you come to the subgroup of patients that are easy but rewarding, those who have epilepsy and then they don't take their medication. Even with the first attempt of giving benzodiazepines, you get very good clinical improvement also. So it's not that bad. But I agree that in many cases this can be really challenging. You administer the benzodiazepine and then yeah, the EEG improves, and you have a better background with disappearing abnormalities, disappearing or decreasing epileptiform discharges, but you cannot monitor the clinical improvement because the patient sleeps. Well, in this case, unfortunately, you need to conclude it as a possible non-convulsive status epilepticus and then monitor it on a longer run.
Very good. Thank you very much. In case of structural brain lesion, like for instance in a stroke, are there any keys how to differentiate structural from epileptical slowing?
Well, not for the interictal. So, but if you see slowing that has a dynamic evolution, then you conclude that this is seizure activity. It's epileptiform, it's epileptic activity, and it's not structural, but not for the interictal.
Thank you very much. We have another question. Is birds an abnormal pattern?
Yes, especially if there is an evolution within the bird, or the location is the same as for the interictal patterns, the other interictal patterns that you see in that patient.
Wonderful. Thank you very much. We are having a lot of questions here that they are being submitted right now. We have another one that it's, can you explain again the difference between using a 10-second sliding window and the 10 minutes of EEG abnormality you later referred to as non-convulsive status epilepticus?
Yes, so the Salzburg criteria, when we discussed them in the first panel discussion in Salzburg in 2003, were meant to cover broadly. Now, our hypothesis was that there is a well-taken clinical indication. So there is a patient who has already fulfilled the clinical criteria. So you have, according to the new ILAE task force definition, you have at least a 10 minutes period with clinical symptoms, and then you do the EEG. And in that case, the 10-second was just the climax of the EEG, so the whole recording is abnormal, but you need at least 10 seconds where the abnormalities are so expressed that you fulfill during these 10 seconds the Salzburg criteria. Now, the drawback of this approach is that obviously you cannot apply this to a patient who has been in an intensive care unit, because you cannot detect when the 10 minutes of clinical symptoms occurred. So for these patients, so the critically ill patients, intensive care unit, comatose patients, there you extend this 10-second period to the 10 minutes because you simply don't have any clinical criterion to combine it with the EEG criteria.
Very good. Thank you very much. We have another question here. Is altered mental status frequent in non-convulsive status epilepticus?
Yes, it is. So it's in the vast majority of the patients we do EEG on suspicion of non-convulsive status epilepticus.
We have another question, which is, can PLEDs without clinical disappear after diazepam administration?
Sorry, can you repeat the question again? Can PLEDs without clinic disappear after diazepam administration? LPDs, you mean? So
yes.
So can LPDs?
Yes. Can without clinic disappear after diazepam administration? I believe that's this question.
Oh, yes, absolutely, yes.
Very good.
So that's why just the modulatory effect on the EEG is not enough.
We have another question. Can EEG differentiate epileptic seizures and dyskinesia in autoimmune encephalitis, like in NMDR patients?
Yeah, that's a good question. So usually you can see facial brachial dyskinesia in patients with LGI1 antibodies, and there we do believe that there is an epileptic genesis to it. Now, in patients with NMDR antibodies with EEG, you can see the so-called extreme delta brushes, where you have a intermixture between delta activity and beta activity.
Wonderful. We have another interesting question. Is it possible to differentiate between Creutzfeldt-Jakob disease versus non-convulsive status epilepticus?
Well, I must say that it's the whole clinical picture that helps you in differentiating. Often EEG can there be an overlap between the EEG pattern, but you need the whole clinical picture.
Of course. There is another question that comes in, that it's, for how long do you recommend continuing EEG monitoring after anesthetic withdrawal in order not to miss any non-convulsive status epilepticus?
Well, that's a tricky question, and there is no consensus, or there's no evidence-based guideline, so it varies from center to center. Well, we are quite conservative in applying this because we know that also during the weaning there is this paradox phenomenon. So even during the weaning, if you see these patterns, then their relevance is very questionable. And then after that, we mainly rely on monitoring the clinical symptoms, and if there is indication, then we put the patient back on CEG, but we don't monitor in default mode after that.
We have another question that asks us what's the most common reasons for non-convulsive status epilepticus in patients?
Well, this depends on where you work. So I have two affiliations. One is an epilepsy center. So here, most of the patients with non-convulsive status epilepticus have developmental epileptic encephalopathy, and patients who have known epilepsy and then they just forget taking their medication, like patients with juvenile myoclonic epilepsy who go out partying and then they don't take the drugs. Now, the situation is completely different at my other hospital, other affiliation, which is a university hospital, which has intensive care unit. Well, here, of course, the major causes are after cardiac arrest and patients in the ICU who do not have another explanation for their altered consciousness. So it really depends very much on your patient population.
Thank you. We are being really having a lot of questions here, which is good because people have been very attentive and asking for all of these interesting questions. Would you expect to find MRI correlate for patients in non-convulsive status epilepticus? I believe that this is like what you expect to see on the MRI.
Yeah, that's a very interesting question. I must admit I'm not a neuroimaging expert, but I'm aware of several publications that showed MR changes, especially in the diffusion-weighted imaging during status epilepticus. But this is not my top expertise.
Another question is, what is the recommended time for burst suppression when treating a patient with PLEDs?
Well, again, this varies very much from center to center. So as I mentioned, in our center, we try to target this 5 seconds versus 8 to 12 seconds. But again, this is what we do, and I don't claim that this is the best. As far as I know, there is no evidence-based recommendation for this.
We are actually having a lot of questions about this situation on burst suppression, but I think you addressed these ones. We have another question about if you could recommend steps to distinguish between hypoxic brain damage and status epilepticus.
Yeah. Well, again, this is a very complex question because the original classification was that the status epilepticus can be because of structural brain damage or because an epileptiform dysfunction. And then depending on the proportion of these, of the combination of these factors, you have a poorer or a better etiology. Now, you can have non-convulsive status epilepticus also in the patients with hypoxic brain damage. It's very difficult to distinguish between the two, but generally this means a poor prognosis, although there are cases where patients survive. So for example, if their SEPs, the somatosensory evoked potentials, are preserved and the bulbar reflexes are reserved, then as Andrea Rossetti nicely demonstrated, these patients have a chance to survive. But otherwise, the prognosis is poor because there is a higher proportion of structural brain damage in these patients.
Thank you very much. We have another participant asking you if you could please elaborate about ictal-interictal continuum pattern recognition.
Yeah, so this is a concept which is still in evolution, but the way it's interpreted in most centers is that you have those patients where the criteria for seizure or status epilepticus are not fulfilled, but you can see clearly malignant patterns. So, for example, if you see the LPDs, or if you see the GPDs or lateralized rhythmic delta activity with frequency higher than 1.5 Hertz, or with the plus modifiers, or if you see spike and waves, but not at a frequency higher than 2.5 Hertz, so you can't call it yet a seizure, but it's more than 1 Hertz, then in most centers you would classify this into the ictal-interictal continuum. But this is still a concept in evolution.
Thank you. We have time for another couple of questions before we conclude. There is a very interesting question here about sometimes some centers, they don't have resources for continuous EEG. So assuming that continuous EEG monitoring is not possible, is not available, how many spot EEGs, how many single EEGs do you think should be carried out in the first 24 to 48 hours on a case of a non-compulsive status epilepticus?
Yes, that's a very, very good question, and there is a Swiss study that specifically addressed this. To the best of my knowledge, it's completed but not yet published, so I'm really waiting for the results too. So they did a randomized prospective trial where they compared exactly the outcome in these two cases, so continuous EEG versus repeated standard EEGs. So this will be a really relevant study, so I'm looking myself forward to seeing the results.
Thank you very much, and we are going to conclude with one question that it's not related to the pandemic. Is any patients with COVID positive, have you seen any EEG abnormalities in your experience, if you have observed any patients with COVID?
Yes, unfortunately, yes, but not where I could say that the EEG abnormalities were directly attributed to the virus. So I haven't seen anything that I would call an encephalitis or any direct cause of the virus. Of course, patients who are comatose because of general collapse of their cardiorespiratory functions, they have obviously EEG changes, but not directly attributed to the viral infection.
Thank you very much. We are really reaching the end of today's session, and we exhausted our time. So I'm just going to say thank you for everyone that attended today. Thank you mostly to you, Professor Beniczky, for your excellent and enlightening presentation, and of course our audience for your engagement and great questions. Once you leave today's webinar, you will receive a survey on the presentation that we would appreciate if you could complete that and provide your feedback. You're also going to receive a follow-up email with a link to the recording of today's webinar. If you have any questions, please contact us via email. And if you are interested in future events, you can always register into our Neuro Training Academy. The registration is free. We are always conducting a lot of interesting events. And on the behalf of Natus and our Neuro Training Academy, we would like so much to thank you for joining us today. And we hope that you have a great day and evening ahead of you, and hope to see you some next time. Thank you very much.
Thank you. Thank you. Goodbye.
Thank you.